briefing, we talked about cities and states spending more on police while basic pandemic needs like healthcare go underfunded. And right now, the same thing is happening at the federal level with the military. So instead of providing, massive relief to working families, states and cities with the things that ordinary folks need to recover, the Trump administration is proposing multi-billion-dollar increases in the already record high $700 billion military spending budget. And this is while threatening to allow states who have needs to go bankrupt. We're talking today about long-term priorities and how we've been spending taxpayer money and the consolidation of budgetary power during this pandemic by groups like the military, like law enforcement, and corporate forces happening at the state, local, and federal levels. Representative Mark Pocan has been talking about these issues since long before the pandemic and is now leading an effort to bring accountability to the ongoing military police corporate pandemic power grab. He and Representative Barbara Lee have recently co-authored a letter to the House Armed Services Committee calling for a budget freeze or reduction to free up more resources to send them into the pandemic response vein. To help and try to refocus priorities, he's also proposed the Emergency Production Act, which would allow Congress to direct the president to use the Defense Production Act to designate all supplies and any future COVID vaccine as critical material essential to the national defense, which seems to be pretty reasonable. PPE and vaccines are absolutely what we are going to need to recover as a nation. So today, we are excited to be joined by the congressman and also by Harris County Commissioner Rodney Ellis, who's working to create relief for impacted communities through rent, utilities, childcare, food support, all the basic needs. He's doing this through the upcoming recently doubled $30 million Harris County COVID-19 Relief Fund, an amazing achievement at the local level. And finally, we have public health expert, Dr. Ali Raja. He's an associate professor at Harvard Medical School and executive vice chair of the Department of Emergency Medicine at Mass General Hospital. He's also co-founder of an incredible grassroots organization called GetUsPPE.org. The mission is probably pretty clear from the title, but it focuses on addressing personal protective equipment shortages for healthcare workers across the country. So he's here to talk about what mass testing is and what it means to pandemic response. So first of all, thank you so much to our panel for joining us and being here with us today. I'll begin with Representative Pocan. So your letter to the House Armed Services Committee was co-authored by you and Representative Barbara Lee, the only member of Congress to vote against the 2001 authorization for the use of military force and subsequently against the Iraq War. So this letter calls for a reduced military budget for the next year in response to the pandemic. What's been happening these days in terms of military spending versus pandemic response spending?
Well, thank you for that question, and thanks to all the panelists for being here today. This was a letter that really the issue has predated even the coronavirus, is the fact that we have a military that is expanded too quickly, even at a time of peace. Just in the last 3 years, the military budget has increased 20% in the last 3 years at a time of peace. And the budgeted right now this year, it's authorized for $738 billion. Barbara Lee and I, along with 27 other colleagues, so 29 of us altogether, wrote a letter saying enough is enough. This is a time that we have a common enemy. It's the coronavirus. We should be putting all attention and focus on that. We fund the CDC at about $8 billion. 90 times more money is spent on defense than on the CDC. And clearly, if you ask anyone across the country right now, what's the biggest threat they're facing? It's COVID-19. This is a time to redirect that funding and to get our priorities straight and make sure that we're getting money to the very things that Dr. Raja is talking about. I'm writing a letter today to FEMA. Our state is having issues getting things, which is holding us back and getting testing done. So this money could be better spent on COVID-19 than on defense.
It makes perfect sense to anyone living through this pandemic. So let me ask you about the Defense Production Act, because it's something that we've heard a lot about, and I'm not sure everyone's had a chance to really absorb what it means. So what is the Defense Production Act? How has it been used up until now during the pandemic? And what would your Emergency Production Act do to change that?
Sure. Well, what we're trying to do is take the power of the Defense Production Act, which is pretty strong power, And since the president's not utilizing it, give it to Congress to force the president, because it has to be still the executive branch power, but we can take a vote of Congress under the proposal that we have. The Defense Production Act goes back to the Korean War in the 1950s. It was used to give the president broad authorities to influence any domestic industries in the interest of national defense. But national defense includes public health emergencies. So, we have tried to get this to produce more of the PPEs, the reagents to perform the tests, other things that we need to in this country, because so much is produced overseas that we don't produce very much here anymore. And we have serious shortages in supplies. The president said back on March 18th that he was going to use the Defense Production Act, but he waited until April 8th before he started using it. And even to date, I think there's only about 10 instances where he's used this. And, we're in severe shortages. In Wisconsin, within a week, we run out of gowns for people in our facilities. We've got serious shortages on swabs, on reagents, and no one wants to get us reagents. Even FEMA is telling us, go talk to CDC, and they'll only do for public entities. So we have a serious problem why we can't test more people. This is just kind of common sense that we need something to put in place. We asked for 270,000 gowns from FEMA. We got zero. This month. And that's a letter we're writing to them today. But you could have got around that if you had the president say, companies, I need you to step up and produce some of these goods. He did it 10 times, but we need it probably 100 times in a lot of different areas to make sure that everyone has the capacity as a frontline worker in a hospital or a clinic to be able to do this, as well as the other needs that we have. So this bill, again, would essentially say Congress could vote on this to authorize the president to do what he needs to. And we have serious needs in this country. And I think you're going to hear about that more in depth in a little bit.
Indeed, we are definitely going to delve into each of these issues. But before we go full medical, I wanted to ask you a little bit about mass testing. We've talked a lot about, in the national conversation, we've been talking a lot about the need to dramatically expand testing. And I think we're going to drill down on why that's so important to the ability to reopen the country in a minute. But specifically with regard to testing, what do you think the federal response needs to be in order to get us to a place where we can begin testing on a meaningfully massive scale? And how would you use the Defense Production Act to address that?
Well, first of all, there is no national plan for testing, other than the president keeps telling you we have the most tests. We also have the most deaths. And he doesn't like to share those two in the same sentences. When I left Washington now, probably 10 weeks ago, when we were meeting on a regular basis, they told us they had 5 million tests ready to go the next week. And then it took another, I think, 5 or 6 weeks to get to the point that they were able to run 5 million tests in the country, because we just aren't prepared and there isn't a plan. And the president's trying to say it's up to states, but states then are competing against each other for these goods. So one of the things that we need in Wisconsin, for example, we have over 50 labs doing tests. Yesterday was our largest number ever, but most of those labs can't perform the tests that they have full capacity to, because they don't have things like reagents. That's one of the things you need to perform the test. We're in severe shortages, I believe, just about everywhere in reagents. And because of it, that's something that you should use the Defense Production Act for, to get reagents done by companies in the United States. We're fortunate in Wisconsin. We have a company called Exact Sciences that has the Cologuard colorectal test that's converting to doing these tests now for COVID. And we have another company, Promega, that's actually making reagents for that type of test. So we actually have this great capacity. We still have some logistical issues that if there was a national plan, you'd figure out how to test every frontline worker, every essential worker in any type of job, have everyone who goes to a hospital or clinic, no matter for what, getting tested, ways to get those numbers up to where we have to. We should be at minimum at 1% of the population a week. And there's other numbers that people throw out there, but that's one that I believe, I think in the most strongly. And yet we're not there yet in many places, because we don't have the supplies we need to get the tests, and we don't have a national plan to get the tests. So we force governors to either act individually or regionally to do this. We're bidding against each other for goods, driving up the costs. That doesn't help anyone. And at the end of the day, it'd be so much better if we had these done directly through the Defense Production Act. We've provided money to states to do some of this, but it's not going to be nearly enough to do the testing that we need to get the capacity to, and to get the product we need to run the tests.
Yeah, no national plan seems like the theme of 2020. I mean, among many other really awful themes. Okay, so I'd like to turn to Dr. Raja to talk with us about the medical side of of these needs. Dr. Raja, you've been advocating for increased awareness of the dangers of COVID-19 and for more personal protective equipment for healthcare workers. So how did we get to where we are, speaking of no national plan, and what has gone wrong, and has anything gone right?
Thanks, Emily. I'd like to think that some things have gone right, but you're right, there's been a lot that's gone wrong. Just building off of everything Representative Pocan just said, he was exactly right in that this is a multifactorial problem. One of the biggest issues that we don't talk about enough is that over the past decade or two, we have stopped, as the US, we have stopped producing a lot of PPE, and we've been outsourcing a lot of it. In fact, prior to the COVID-19 outbreak, over half of PPE production in the world was actually coming out of China. And this began in Wuhan. You can imagine that China actually needed a lot of that PPE. But then on top of that, as COVID-19 spread around China, a lot of the workers in these PPE, the personal protective equipment factories, couldn't go to work. So not only was China not willing or able to export PPE, it wasn't able to produce it either. And the rest of the world, especially the US, we weren't ready to step into that gap. And that's not just true of masks. We talk a lot about masks, but that's true of everything from booties to hand sanitizer and everything in between. We've got a lot of of demand that we just haven't met for all of that supply. So on top of that, one of the other fundamental things that just seemed right when we did, but actually wasn't the right decision in the long run, was we switched at most hospitals in the country from stockpiling supplies to just-in-time supply ordering. We did that at a lot of large hospitals here in Boston, and we did that all over the world as a way of shaving down on the amount of unused inventory that we had sitting around in stockpiles. Well, it turns out that that's fine when you've got steady and predictable supply. But when you, like we did, nobody, not just individual hospitals, but nobody in terms of states and even the federal government had a stockpile large enough to meet that demand when we had switched to just-in-time ordering. On top of that, ramping up production for this PPE takes time. And it turns out we actually needed it now or yesterday rather than months and months. And this wasn't as predictable as a lot of us thought that it would be. We thought that, oh, sure, we might need something like this, but we'll be able to predictably ramp up production. We didn't have that lead time. And that's what got us into the situation that we are in now.
Oh, man. Well, given where we are, how should a system be set up for the kind of national testing that will be needed to safely reopen the country? And how much protective gear are we now creating, and how much should we be creating?
The number that Representative Pocan spoke about is actually the same one that I use and that I think a lot of people use, is that we want to be testing about 1% of the population every day. As he mentioned, we're nowhere near that. And the fact is that we'd ideally like to get there and beyond so we can test everybody. But since we don't have that capability, right now what we're doing is we're spending a lot of testing on symptomatic people. But what we want to move to is we actually want to move to a situation where we're able to test communities, high-risk communities especially, even patients, even people, because they won't be patients who aren't symptomatic at all. We've started doing some of that with some trials in Chelsea here in Boston. It's a very diverse community with a lot of Latin and African American, I keep wanting to call these people patients, but they're not patients yet. They're healthy people who we're testing to find out whether or not there's community spread. And by doing that, we can actually find people who are testing positive but are not symptomatic and help them isolate and quarantine themselves so they don't actually spread it. That's the kind of testing that we need, not just of symptomatic patients, but of communities as a whole.
So if we did that, if we had unlimited testing and abundant PPE, and like if we gave you a magic wand or a genie in a bottle or like whatever it takes to get there, how would that impact the death rate? And like, how does that kind of intervention compare to the development of a vaccine, for example?
It's a great question. Remember that we're not talking about PPE or a vaccine. It's always going to need both. Vaccines are inherently imperfect. They don't work as well in elderly patients, which is what COVID tends to be hitting. And on top of that, vaccines take time. And as we mentioned in our pre-call discussion, vaccines don't not just need to be efficacious, they don't need to work, they also need to be safe. There's been some vaccines in the past. There was a vaccine for dengue fever that I can remember that actually did more harm than good. So we really needed a lot of testing. Then we need the production of the vaccines to be ramped up the same way that PPE is. But if we were able to get a vaccine that was effective, especially in elderly patients, the final thing that we might not be aware of is that the reason that we vaccinate people for pneumonia and the flu year after year is that sometimes the virus itself changes over time. We've had some hints of that happening even with COVID-19. So even if we have a vaccine that works for 1 year, we may need to revaccinate people in future years as well. So with the vaccine, with effective PPE, if I just got that magic wand, we should be able to substantially lower the death rate. But that's a long time away. And getting that PPE is essential to all of that.
It seems like the most manageable near-term possibility from everything you've said. And I want to talk, because no national plan was the theme, and because so much of this response has had to happen on the local level, I want to turn now to Commissioner Ellis from Harris County, Texas. Commissioner, so we talked on the program earlier about the tension between police funding and pandemic response budget priorities. Do we need to be pouring money into law enforcement right now, or are there more urgent needs? And Representative Pocan has been talking about these similar questions on a federal level. So I'd love to talk with you about the crisis specifically in your city. You decided to take action, and you did this incredible thing, which is a $30 million relief fund. Can you talk to us about how you came to that decision and how you balanced some of those interests in terms of the response that you've chosen?
Well, Emily, thank you for the question. And Congressman, thank you for letting me join you. I remember your career when you were in state government, by the way, and you followed through on those progressive values. Look, we're a massive region, about 5 million people in Harris County, most diverse county in the country. Houston is the base, but we have a population larger than 25 states. And I really looked at what was happening in Los Angeles. I think they were fortunate that the Open Society Foundation stepped up. I think maybe put in about 25 million or so, and they had the Angelina card. So I talked with our county judge. We have a 5-person governing board, so I can only talk to one. So I spoke to the county judge, and we were looking at $15 million. We were impressed with what the city of Austin did on a local level, with about a fourth of our population. They put up $1 million, and I was impressed with that. But we wanted to make sure we had a big enough pot to have an impact. We have a large immigrant community. Houston's about 2.2 million people. There are more people in unincorporated Harris County than in the city of Houston, by the way. So we wanted to make sure, knowing the federal government maybe would not be as thoughtful in terms of what they would do for our immigrant population, which is part of the backbone of our economy. They pay taxes, property taxes, sales taxes, income taxes. So she and I just decided we'd roll the dice. We'd go big. Everything's big in Texas. It's still not big enough. So we agreed on 30 million that we push, and we were fortunate we had the support of a third member of the governing board, and he agreed, former sheriff, now County Commissioner Adrian Garcia. So that the three of us did support it. Look, here's what we did I think was big. We looked at it with an equity lens. You can't just go distribute this money, in my judgment, on a first come, first served basis, because who's more apt to be prepared when you do that? The more affluent of the least affluent. So we didn't do that. We're going to run the money through the Houston Community Foundation. It takes time to find people who really need. I call them people who catch the early bus. We don't see them because when we go to work, they're already out. They made it there early. So 30 million is it's a big number. It's the largest one locally funded. Here's the last point. We took it out of our emergency fund. We don't know if we'll get reimbursed under the Federal CARES Act, probably because we're not going to discriminate against our immigrants. We may not get reimbursed for most of it. But here's my thought. We took it out of the emergency fund, and if COVID doesn't qualify as an emergency, they ought to change the name of the fund. So that's what we did, and that's why we did it.
That's fantastic. And I especially want to highlight, it's not every day that one sees politicians taking risks that are real risks, that risk really big money on behalf of ordinary people, which is really what we ideally elect politicians to do, right? Is to protect people over money. and to take the risk of protecting your immigrant community when you don't know if you're going to get reimbursed because of it, because of certain policies on the federal level. It's very encouraging about leadership in our country. So speaking of the uncertainties of federal support, I want to go back in time for a minute, because this isn't the first time that Harris County has had to deal with an emergency. In fact, just a few years ago, there was the hurricane that required a FEMA response. And I'd be curious to know what you've learned about federal support in the emergency context through these, the hurricanes, the storms, FEMA involvement. How can federal support help? And what else is needed now in order to shore up the vulnerabilities of cities and counties?
We couldn't make it without our federal partners. We're unique in America compared to other governing bodies around the world because we can print money on the federal level. You got to pay it. At some point, you got to dance with the piper. At some point, you got to raise taxes to service that debt. But on the local level, we have to balance our budgets. Look, I was in the state legislature for 26 years. I had no idea that when federal money is distributed for a disaster through FEMA and other entities, they use something called a cost-benefit ratio. Now, apply that to Katrina as opposed to Harvey. That means you would never get around to giving money to the Ninth Ward in New Orleans because the houses just didn't cost enough. And so, look, I did the research once I made the switch from state to county government. As it turns out, cost-benefit ratio comes from an old executive order signed by President Ronald Reagan that I think has been distorted a bit. But they decided they would value downtown, the medical center, the more affluent neighborhoods in Wisconsin or wherever over the poorer neighborhoods. And so that's a real problem. So after Harvey, we passed a $2.5 billion local bond issue. We thought we were going to get $1 billion from the feds, $1 billion from the state. We may not get it. But on our money, we use a social vulnerability index. So as opposed to looking at the value of property, look at how many people live in the neighborhood. Look at how many of them have cars. Look at not whether or not they just flooded from Harvey, neighborhoods that flood every time. And I hope that our federal partners, Congressman, and you and Congresswoman Lee and others, Barbara Lee and Sheila Jackson and others, I hope will lead that charge. Get rid of that cost-benefit ratio. That's old school, it's crazy, and it values property over people. Now, with most HUD money, they use LMI, low to moderate income factor, and that helps. But a good bit of the disaster money does not come through that LMI, low to moderate income index. And look, I'm just embarrassed, 26 years as a state senator. Hell, I didn't know it. Nobody ever told me. And when I made this switch, my head of flood control wanted me to go to my local Congress people, then Congressman Gene Green, Sheila Jackson Lee, and Al Green, and get them to make the case to get rid of this cost-benefit ratio. And when I did the research, you want me to get them to go get the Trump administration to overrule the Ronald Reagan executive order? Please, what are you drinking? But we need to get rid of that. I mean, when you think about it, I'm not saying you don't protect downtown and the medical center. They're important to in every community, they're important. But you can't just always value in an emergency with federal money, property values over people.
So that actually raises a really interesting question for me. Representative Pocan, I want to give you a chance to respond to Dr. Raja and to Commissioner Ellis. And I also want to know, has anything like a social vulnerability index passed across your desk? Do you want Commissioner Ellis to shoot you an email with what he's using? Can we forge that connection here? Please take a moment, take as much time as you'd like to respond to what you've heard from the local folks here today.
Yeah, no, thank you very much. And absolutely send me the info. One of the things that we're noticing right now with FEMA, and I think it relates to both of the conversations, is, FEMA is still not functioning in a way that should have emergency management in the name of FEMA, because they're not replying in a way that we need it. When we've asked for goods at the end of March in Wisconsin, and for a month, I don't think we got anything until we started really complaining in the final few days. We got like 1% of one category, 1% of our reagents, 5% of I think our some of our PPE, and about 25% of some of the tests we needed. So we've had to sit down, and I've met with the regional director of FEMA when he came through recently. We did another letter, and we're about to show what they did this time. They did a little better in getting us some PPE, specifically masks. But what's interesting is they gave us supplies, swabs that we can't use for COVID-19 tests because they're the wrong kind of swab. They gave us a number of things that aren't even usable, which is incomprehensible. And then on the reagents that we need to actually run the tests, they said, well, go to the CDC for that. So now they're trying to put another agency involved instead of one agency under federal control doing this. And don't forget, for a while, they were going to get us goods back at end of March. Then they changed the order April 8th to they'll count anything that any state or local government got off the private sector as what they got for you. And now they changed it back to they'll get us some goods, but not all goods. I don't understand it. I doubt, the doctor does or Rodney does, and it's just a mess. So we need to have that consistent amount of supplies. And I completely agree that if we had that magic wand and we had the PPEs, it's going to take a while, and we have to get our testing up, and we have to work on a vaccine and therapeutics as well. I throw therapeutics in. We absolutely have to be doing the very type of testing, the funding that Rodney's putting out there, the type of things that mentioned by Dr. Raja, in order to test enough people so we can see if there's community spread. So then we do the contact tracing, and then we do isolation with support for folks then to make sure that we're getting it down as few people as possible and that those people aren't having contact with others. Honestly, Dr. Fauci and my subcommittee on appropriations for Labor, Human Services, and Education, he told us probably towards the end of February, at that point, maybe it was middle February, if we shut down the nation for 2 weeks, we would have stopped the virus. And we didn't do it at that time. So there's the Columbia University study that's saying just 1 week earlier, had the president acted, you might have over 30,000 more people alive today. But this has been a mistake after mistake after arrogant mistake by this president and this White House, and still not having a national plan and still not addressing the issues that the three of us are all trying to address in our respective roles. So I totally feel the concerns they brought up, the issues they brought up. And like I said, I'm feeling them today. We're reaching out to FEMA one more time, trying to get something to work.
So yeah, let's talk about how to actually concretely make this work. There was a report that just came out from the Justice Collaborative and Data for Progress that indicated through polling that 3/4 of voters, and that's Republicans and Democrats alike, support free and expansive coronavirus testing because everybody wants to live. And I'd love to have each of you take a moment. We'll start with Dr. Raja at the medical level and Commissioner Ellis at the local level, and Congressman Pocan at the federal level, to talk about what the actual barriers are between us right now and creating 1 million free coronavirus tests per day. That's what the experts have said may be necessary. What are the barriers? And I'd also love if we could include in that answer legislative barriers as well. Representative Pocan, I'd love to talk about the chances of success of you pushing your bill through through completely. So let's start with you, Dr. Raja. What's standing in our way concretely that we can break down right now?
Absolutely. So I think that's such a great question. I think that there's three main things that really stand in the way from the medical standpoint. The first is making sure that we have an effective test. There's a lot of potential tests out there, but as we've heard over the news over the past month or so, there's a lot of excitement about a certain test, and all of a sudden we find out, as reported by the CDC recently about the viral antibody tests, that the tests are not as good as we initially thought they were. So the first barrier is developing effective tests that work across a broad population. And so that's number one. Number two is actually scaling those tests up. I spoke about that earlier, and both the commissioner and the representative talked about the issues with broadening out and getting enough tests out there. But number three, and I think this one is often overlooked, and I face it every day when I work here in the hospital and elsewhere, is we actually need to be able to perform the tests. For that, we need to be able to do it safely for healthcare workers, because once healthcare workers start getting sick, they actually spread rather than contain the virus. But we also need to be able to get to vulnerable populations. So I grew up in Houston. And so the commissioner, thank you very much for everything you're doing in Harris County. My folks are still down there. And there's a lot of people in vulnerable neighborhoods who don't have access to transportation. They can't get to clinics. They can't get to their doctors and nurses. We need to get out there and actually do the testing where they are. And that's not something that most places are taking into account right now. So it's a matter of having an effective tests, ramping up production, but then also getting the tests and the patients together, which is often not in clinics or hospitals. It's often in their homes.
Yeah, let's turn to the commissioner about that, because you're dealing with a region as massive as Harris County, as massive and as diverse. What are the barriers to implementation of large scale testing?
Well, obviously, money is always a factor, but it's money and leadership. First of all, a willingness to pay for it, and then a willingness to do it. Look, I went and took the antibody test, and I remember going to this hospital. It was on my insurance, and it's because of who I am that someone said, "Hey, come by and we'll do it." I was afraid when I walked up and people looks like they in a space suits, going in. Now I find out the antibody test doesn't really do that much, but it begin with money. Are we going to pay for it? And then picking the right test. The congressman has alluded to PPE. I've had more people calling me selling all kinds of schemes. I didn't know so many people had access to PPE, but we got to be willing to pay for it. We ought to be embarrassed to be in the wealthiest country in the world, and so many of our colleagues in other countries around the globe are doing a better job at testing. And I think some of that is because people don't want the testing, because that would get people to stay home. I mean, if we really knew how many people out there are positive and maybe just did not have a reaction, more of us would take it a lot more seriously about wearing masks, washing our hands, and staying the heck at home.
Representative Pocan, what can you talk to us about the barriers that you're facing right now? Especially, I mean, if money is the issue, you're fighting to get the money with the Defense Production Act. So what are your chances of bringing home the money? What can you tell us?
Well, I see it as leadership kind of in logistics, which includes getting the money and the capacity expansion that was talked about. First of all, leadership, we have none. Right now, we have a president who won't wear a mask. And I truly believe the only reason he doesn't want to wear a mask is because it reminds him of the 100,000 people that have died because of his poor choices over the last several months. But that's not something that, we all have to get over this mask issue. And fortunately, most people really do, but we need the leadership. So if he can't even get over a mask, how are you going to get over the fact that you didn't get tests out there sooner? You're not getting the right types of tests. You're not getting the funding out there. You're not getting the expansion of who's being tested correctly. So part of it is just a leadership issue. And the second part that kind of translates to the logistics of it as well is we have a Senate right now that's not even in this week that has refused to act on a second giant CARES bill with the HEROES Act that we passed. So because they didn't come to a table, we put out a $3 trillion bill, the largest bill in federal history, because it takes resources, like the commissioner said, because it takes us protecting the frontline workers, like Dr. Raja is talking about. And all of that we put in the bill, but we still don't have the Senate coming to the table. And what I'm worried about is, for people unemployed or people who small businesses got PPP loans, right now, for many of them, they're in week 7 of 8 weeks. After next week, you're going to have a huge spike in unemployment numbers going back in the states because of what's going on. So I hope that on the defense production side, that's something that would be under that leadership the president should do. That bill is something I think is reasonable. Why shouldn't Congress, as a co-equal branch of government, also be able to help direct that if you have a president who won't do it? On defense spending, it's a harder nut to crack. The problem is every single district has defense contractors, people making money from the defense industry. That allows constituents to call up and say, keep funding things. I have a company that makes a little piece, a little smaller than 2 parts of my finger for submarines, and every year wants me to buy more submarines than the Department of Defense asks for. It's ridiculous, but that's the reality we have. So very few of us are sometimes willing to speak out on that, but we're going to continue to, because I think the American people really are with us on these issues. It's once again, if the people lead, eventually the leaders will follow. I really believe in that. We need to get that done.
Thank you for that, and for your leadership on this. I think it's an interesting moment to consider this dichotomy of military spending versus spending on pandemic response, because it really goes to the root of how people think of safety. Do they think of safety in terms of guns and the military and police, perhaps this week less than ever? Or do they think of safety in terms of healthcare workers, frontline first responders, their hospitals, and the development of innovations that could keep us all healthy? So I want to thank each of our panelists for reflecting on this difficult question with us today, and for all the work that you are all doing individually in different sides of this problem to try and keep us all safe and move money towards a better idea of safety. Thank you each for joining us. I'm Emily Galvan-Almanza. This has been The Briefing, and we will see you tomorrow for a number of candidate forums, which we're very excited to be presenting. Check our Twitter feed and our Facebook feed for more info.